Good morning, good afternoon, and good evening to you all, depending on where you are joining from. My name is Sylvester Moyo, and I'm delighted to be your host today. Today's focus will be an extremely important topic titled Success Stories and Challenges in Implementing Infection Prevention and Control in Resource-Limited Settings. As we continue to confront the growing threat of AMR, IPC, which is Infection Prevention and Control, remains one of the most powerful and cost-effective interventions for breaking the chain of transmission of infectious agents. And this is particularly the case in resource-limited environments where the burden is often the highest. In today's session, we will explore practical experiences, lessons learned, and what it takes to strengthen IPC implementation. We'll also reflect on how these efforts directly impact AMR containment in both clinical and public health contexts. It is now my pleasure to introduce today's esteemed presenter, Prof. Gunturu Revathi, who is the head of the clinical microbiology at the Aga Khan University Hospital in Nairobi, Kenya. She brings a wealth of experience in microbiology, IPC, and AMR surveillance, and she has held influential roles across India and Kenya, including with the Kenyatta National Hospital, the University of Nairobi, and several national technical advisory committees. Her research interests span antimicrobial resistance, stewardship, diagnostics, and the One Health aspects of tuberculosis. She has published over 150 peer-reviewed papers and supervised more than 70 postgraduate projects, and continues to lead and collaborate on impactful research across Africa and globally. She is also currently the chair of IPNet Kenya, a professional society that champions IPC education as a frontline strategy in the fight against infectious diseases and more specifically AMR. Prof. Revathi, we are honored to have you with us today. Over to you.
Thank you very much, Sylvester. First and foremost, thank you very much, ASLM, and all the organizers for giving me this lovely opportunity to share a few of the perspectives on IPC and the current challenges we have because we are in the low middle income countries. And basically what I want to cover, I'm not covering, concentrated topics like how to do the interventions, what are the impacts, that kind of concentrated stuff. The 30 minutes and 15 minutes discussion which we have, I just want to stimulate some thinking and also some updates for people to go and read. And we will also share a lot of resources which people can refer to. So, slide. One second. This is just an invocation for the goddess of fine arts, especially education and wisdom, because we see more and more education without wisdom is not taking us very far in the current world. I have no conflicts of interest related to this particular presentation. And these are my objectives. Review effective IPC strategies tailored for resource-limited environments. I'll show you some resources around this and also some truth about these things. Essential IPC interventions and what are the recent developments, some barriers, something about behavioral science, and also there are a lot of recent advances, whether they are available in low resource setting, but they help to conserve resources. And these are all the references which I have used to make this presentation. And most of the slides, they are all from free websites. There is no copyright. All these WHO, CDC, BSAC, ASM, and clinical care options, global smart site, and also Michael and Margit. and also Asmita Charani, Open Education Source, Medscape. These are all the resources. Quickly about my background, I'm a clinical microbiologist and I'm a clinician trained in microbiology. This is my hospital, Aga Khan University Hospital in Nairobi. That is our medical college, East Africa, where I'm sitting right now. And this is our quality systems in place. South Africa National Accreditation for the Laboratory, College of American Pathologists certification for all the diagnostic laboratories, and Joint Commission International Accreditation to the hospital. Those are the quality standards. And this is our ICU. Here, ICU is the playground for IPC, AMR, and many MDR bugs, critical patients, life and death, round the clock 24/7. And this is the ground where all these problems are concentrated. Here we have a standard certified ICU with each patient in a separate room. But this is a high resource private hospital. Is it possible for low resource countries to have this kind of nursing? That is a debatable thing. And this is our isolation room. We have 5 of these isolation rooms, and there is a buffer zone. Inside there is a patient, but there is an ante-room where the healthcare worker is supposed to wear PPEs, the masks, the gown, the caps and gloves, change everything before you enter, as you come out. So this is the isolation room for COVID, TB, influenza, bird flu, what have you. This is the core laboratory chemistry. This is my molecular diagnostics and my microbiologists. And now come to the topic today, which is now Florence Nightingale. We go back to history. Very first requirement in a hospital is it should do the sick no harm. Whether you are able to heal him or not, but don't send him back with another infection, an MDR, Klebsiella, or hepatitis C. Don't do that. Treatment without prevention is simply unsustainable. This is Bill Gates. We have to now quote the rich people on the earth who have been philanthropists. They have been funding a lot of our countries. Our resources are coming from those projects. Truth now, the climate change. The climate change has changed the infectious diseases background. We have now fungal infections which never heard of because of the warming and the lack of water and the temperatures, global temperatures rising. And now antibiotics. Now this is 100 kilograms of enofloxacin, which is used in a farm by a farmer. It just costs $15 on Alibaba.com website. And then now we are asking doctors to use antibiotics very judiciously, 400 milligrams, 800 milligrams, only 2 days or 3 days. You are trying to teach the doctor, but the farmer has used 100 kilograms at a go in a farm. So these are the paradoxes we have to think about. And now this is the LMIC. This is where we are. We have AMR control, IPC issues, infection prevention issues, emerging pathogens, climate change, all of them. And LMIC is finding it very, very daunting. Now, when the high-income countries and low-middle-income countries, they interact, you see the hegemony, how the higher-income country is trying to teach the low-income country, yet they are not used to the low-resource setting, yet they are trying to teach. Sometimes they have a lot of knowledge, but here in low-income country, we need wisdom to apply that knowledge. So the risk of acquiring HAI, hospital-acquired infection, is 20 times higher in low-income setting. And healthcare environment can act as an amplifier of these infections. That is, a patient can come into a healthcare facility without precautions, without hand washing, no water, no resources, no nursing staff, enough to cover. And now he comes into the hospital with a multi-resistant Klebsiella. He gives it to 30 patients. When they go home, they spread it to another 300 people. This is how a hospital is an amplifier of multi-resistant bugs. This is the truth on the ground. Safe water is what we need. And this is again the discard waste from the hospitals, how it is looking here. Now, this is our Ebola setting in Africa, how patients were being treated in an Ebola ward. And this is the high income setting. You see the great difference between these two settings, but both had the same objective. Without diagnosis, without knowing this is the pathogen, how do we direct treatment? How do we prevent it? Now, this is the laboratory. Now, on one side, you have the high-income laboratory in Aga Khan University Hospital. Patients are able to pay, and there is molecular diagnostic automated system. But the other side, there is this technologist who is run with a microscope under the tree. He's still doing his best. The only resource he has is this microscope. He's giving rapid urine microscopy, stool microscopy. He's giving some rapid malaria test, rapid antigen tests. But if he has that resource, he needs that microscope, he needs some reagents and some training. But if those things are not there, sitting under the tree, he can do nothing. So some resources are still required. That's what I'm trying to say. Now, this is the changed global scenario. President Trump just signed on his day one in the office and changed the globe tremendously. CDC website closed. This page you are looking for cannot be found. This is the CDC website. And then this is another website which is talking about CDCC community collaboration, mini grant program. It says this funding record is inactive. All these things were closed. And now Trump is backtracking on some of his policies. This is just July 3rd, just last week. And it is talking about some of the policies which have now reversed. And then measles cases high in USA. Children near the border. This is California in USA. There is sewage crisis from Mexico border. I believe there is a lot of sewage and hydrogen sulfide has poisoned children. This is one of the top tax-paying states in the United States, and the children are exposed to sulfur dioxide from the sewage. So these problems are all coming out now. And this is a traditional medicine in the universities in the USA, where they are practicing Unani medicine, Ayurvedic medicine, and some homeopathic medicine, Chinese herbal medicine, which is coming out now. So recently we have seen many pandemics: Ebola, Middle East respiratory syndrome, MERS-CoV, Sudan virus outbreak, coronavirus, COVID. And HAI is among the most frequent adverse events when these patients get into the hospital. That is the biggest challenge we have. Hypervirulent Klebsiella, which has spread all over the globe. H5N1 all over Europe. Deadly rat-borne hantavirus in USA. It is borne by rats and rodents. This is hantavirus. It causes a hemorrhagic disease, sepsis, and renal failure. And now this is monkeypox. All of you know, you don't have to. Now come to this patient in ICU. Look at all these things which are keeping this patient alive. This is a young guy who met with a road traffic accident and multiple injuries, and now he is in the ICU. If you tide over the crisis, he can live a full life. But what comes in the way of him coming back from heaven is a hospital-acquired infection, which is our topic. All these things we put into perspective as one health: environmental, animal, and human health. All of them are together. And this is a slide from WHO. All of you are familiar with this. 75% of infectious diseases are originating from animals. That's what WHO is telling us. And a lot of infections, as they are circulating, the data comes from USA again, are foodborne. E. coli mainly, Campylobacter, Salmonella, Listeria, these are common in the USA. Listeria we don't see in our environment, but it is very common in the developed world, and they are all foodborne. They are spread by food and fomites. You can see the fork and knife and the plate because fomites also spread it. And the other infections, which are very common, E. coli, animal E. coli, is just by touch with animals or contamination with animal feces. And then can't forget the vector-borne diseases. You have so many conditions We won't go into them. Wild animals, pet animals, livestock, meat, food, humans, interaction with the birds, all this is One Health, and you have sandflies, ticks, midgets, and mosquitoes, and many more insects. Then, recently, this has appeared on the website. Many of the diseases that vectors transmit are considered emerging infectious diseases. That is, some of them we don't know which is the pathogen. It is borne by the mosquito, but until the scientist tells us this is Zika virus, this is this virus ABCDEXY, until then we don't know. So these are emerging infectious diseases. Most of them are viruses which have come from the animals and getting adapted to other animals, primates, and then to humans. So it's a challenge, continuous challenge for scientists to be keeping track of them. Now the perspectives. Glove usage guidelines. This one has come just in February this year. Glove usage guidelines from the Joint Commission, CDC, and WHO. Does it mean that we didn't know how to use gloves before we had this directive? Absolutely, it looks like it. People were using gloves, but they were not using them properly. So there is a guideline how to use gloves. Can you believe this? And this has come from a consortium, CDC, WHO, and the Joint Commission International. And now we have to keep pace with this. What is this policy? This is a free website. Everybody is welcome to read. Then another one has come out, perspective, the hidden dangers of hospital ventilation. Always infection control practitioners were told that you should have ventilation, exhaust the air and have filtered air into the spaces, then the patients are safe. But now what has come out is that a new study from the University of London is telling us this ventilation may be moving viral particles, but it is not removing them. And they are saying that the viruses are actually spreading inside. Do you understand the implication? Ventilation is moving the viral particles from one place to the other, that is from patient to the other environment, but not removing them. This is very dangerous situation. They are working on the standards. Now, all these are team sports. IPC especially is a team sport. It is not a lone ranger sport. So, National Academies of Science, Engineering, and Medicine. This is again US body. Trump has also affected them. They are now, they had a workshop and they have this, Tita is actually describing how and why the science and practice of team science, how it works, and its relationship to medical practices and IPC particularly. We are talking about an integrated stewardship model comprising of antimicrobial infection prevention and diagnostic stewardship. This is to say that nobody can talk about diagnosis alone, nobody can talk about infection prevention alone, nobody can talk about AMR alone. They all have to be integrated so that we optimize our resources and we optimize the patient's safety and patient outcome. Now, this is the model which is integrating antimicrobial stewardship, infection prevention stewardship, as well as diagnostic stewardship. That is a triangular model. Now, Joint Commission International tells us that for us to implement any of the standards, you need all these things: clinical capacity, clinical environment, and also the resources in terms of the infrastructure and the establishment. So the deep blue is the clinical capacity, that is the staff, documentation, human resource, clinicians, nurses, what have you. Clinical environment is the lab support, radiology support, and pharmaceutical support. That is the clinical environment. And then the establishment is you have availability of guidelines, there is an audit mechanism, there is a training, supervision, certification, and then patient communication and support, patient education. So all these have to be integrated for things to work. But do we have all of them? Look at this chain of infection. This is a famous slide. You have here many modalities which are the players in infection, origin of infection, spread of infection, ultimate outcome of infection. This is called chain of infection. And at every step you can see there is an intervention. Hand washing comes many places. And then immunization, stress reduction, wound covering, PPE, isolation, many interventions at a particular chain. It can break. The chain of infection can be broken by multi-interventions. So this is also called multi-modality IPC model. That is, one break in the chain can be multi-modalities. Like you tackle the reservoir of infection, spread from there to the portal of exit by hand washing, housekeeping. Housekeeping is cleanliness, washing, and disinfecting. So similarly, this is multi-modality break of the chain of infection. This is a very reflective slide, and it is loaded with a lot of information for IPC practitioners. And on each point, there is a whole book written about it. Multimodality strategies, which we have already seen, but what are the 5 modalities? System change to enable IPC practice. Training and education, second one. Monitoring and feedback. Definitely, you should be continuously monitoring, measuring, and improving. If you don't measure, you don't know how to improve. Reminders and communications. Most important these days is communication. And on both sides, with the patients, with the communities, within the doctors, within the departments, within the institutions, and global communications. And the culture of safety. This is a culture change what we require. Now, quickly, these are the resources which talk about low middle income country. How do you do IPC practices? Many publications are there. They are freely available. This is another resource by Vikas Manchanda, Implementing Infection Prevention when resources are limited. There is another infection prevention control in low resource setting. Now, this particular journal has 5 papers, but ask me, did they give us any solutions? The answer is clearly no. If you read through all these, was there any solution I can take? Really no. This is another supplement, environmental cleaning in resource limited setting. I was very hopeful, go and read, and it is going to tell us something, how to do cleaning with no resources. Really no. What it tells you is that environmental cleaning is very important. 3 points on this slide. These are exactly from that paper. It says cleaning is very important. We know that already. Despite well-established guidelines, there are several challenges in resource limited setting. I know we have many challenges. We know it. And then what they end with, say, additional researches on the barriers and implementation gaps and role of collaborative network will provide significant insights. Really, is that helpful? They are only asking additional research should be done. Who will do this research? We know our challenges. We know our resource constraints. What are our constraints? 2 infection preventionists consult in East Africa. This is again on the website. 2 American experts came to East Africa, and then they spent 2 months, and then they wrote a book. And then there are some solutions in that, but these are our problems. This is one of the solutions. You see the top one is actually it is a sensor enabled tap, because you don't have to touch the tap. Don't infect the tap, you wash your hands. The other side now is a resource limited setting. Somebody has a contraption still to wash the hands, but there are differences in both. Both achieve the same purpose, but not with the same resources. So these things we know, and it's not a big solution now. This hand washing contraption which you have, you need water. Supposing there's no tap water in the facility, you have to go to a well and fetch water and then disinfect it with chlorine. Who will do this? Who will go to the well? Who will bring the water? And who will employ this person? Those are many questions. So that's not a big solution. This is our problem. There's no drinking water. So what is the solution which you can write in a book and then you can imitate? This is our problem. Nairobi doctor strike. This was about 6 months ago. In all our settings, we know this in all countries. Doctors are on strike because of poor pay. And now you see that most of these doctors, nurses, pharmacists, all of them were out. And then you can also see They are all in their PPE. They are using the hospital caps, the coats, the gowns and all that. They are on the road with their PPEs. Now, that also shows how much awareness we have. Okay, what is the positive things? Global action plan. WHO has made a global action plan on monitoring framework on infection prevention and control. And then we have this book, National Infection Prevention Control Action Plan. And we have Global Strategy on Infection Prevention and Control. And then this can be adapted by countries. And then hopefully that should lead to some additional funding. So what is the vision of the global strategy on IPC? By 2030, everyone accessing or providing healthcare is safe from associated infection. That is the goal. And then the book it is an open resource on WHO website. You have a lot of wisdom, which tells us a lot of things. So what do we need in resource-limited environments? Effective infection prevention and control. We need simple, accessible practices, frequent hand hygiene, proper waste management, basic environmental cleaning, targeted use of readily available PPEs, like masks which are locally manufactured, maybe gloves locally manufactured, inexpensive, and community-based education to promote hygiene behaviors. Actually, considering the limitations of infrastructure and the limited resources. We all know that compliance with IPC measures is always low. It is not in low-income countries. In all countries, it is very low. This is the cycle of behavior. This is implementation science. We won't go into the details, but the behavior is dictated by capabilities, opportunities, and motivations. And it is a very, very simple application to the medical settings. And then we see that there is a lot of culture. Behavior is influenced by attitudes, perceptions, social norms, cultural things, and also your level in the organization, whether you are a professor, whether you are a nurse, whether you are a cleaner, or you are the CEO, your behavior will be changed by where you are on the social ladder or in the organizational ladder. So a lot of things will be modified based on that. Health inequities drive higher infection risk in Spanish-speaking hospital patients. Kaiser Permanent data. This is in the USA. They said that Spanish-speaking people, they were not given the same medical attention. This is in the rich country, USA. And in the States, there is so much inequities, and that is dictated by behaviors. So now, quickly look at this. This is a pilot. A pilot training has a checklist. 100% compliant. A pilot is training. He will not get a certificate unless he gets 100% compliance marks. If he gets 92, 93, or 99 also, he's thrown out and taken to the training. This is the pilot, the one who is driving the aircraft. Whereas a healthcare worker with 80% compliance and IPC rules is a hero. If your hand washing is 80% compliance, you say it is very good. You can improve, but it is excellent. If it is 90, it is excellent. But both the IPC practitioner and the pilot are involving the safety of human life. High time for a culture change, isn't it? Why is the pilot removed back to the training, but an IPC nurse who is only 80% compliant with hand washing is not removed? What can we do about it? This is food for thought. A lot of education is available online, free. These are all YouTube videos, everything. How to do this, how to do that. But is everything suitable to everybody? Does this shoe fit everyone? No. The life is different and there is no single recipe for everyone. So one needs to choose, and that is why there are medical training colleges. Otherwise, we could have closed all the colleges and asked people to stay with the YouTube. That's not possible. So look at this now, the importance of environment in IPC. This is a conference which is happening next year. It has already happened this month, last month. This is called Association for the Healthcare Environment. This is to show the importance of environment in the healthcare setting. Earlier, we were told that environment is not important, but it has completely changed. Now, this is a website, free website, Public Health Ontario. They have started a course Course overview for IPAC, for environmental cleaning in healthcare. They don't say IPC, they call it IPAC, Infection Prevention and Control, IPAC in Canada. And they have mounted this course. It is free. Anyone can register and then undergo. It is going to start, I think, in August. You can check the calendar, you can register. It's a free course and it has all these modules. And there are many, many other self-directed learning resources which you can do. Now, what is the importance of cleaning in healthcare environment? This is a cleaner. He has got a mop and he's now mopping in a hospital. And that was actually to show you, that is a CDC book. Healthcare facilities, environmental cleaning. This is a standards for environment. And now this actually shows the spread of infection. This is a page from the same book where it is showing how the environment impact actually is conducting the spread of infections in the healthcare environment between the patients in the hospital and the community, MDR spread. And now these are all the gadgets which are also spreading the infections. So what is new here? You have what is called far UVC game-changing impact on indoor air quality. These are the lamps. These are far UVC lamps. This is not ordinary UVC. It's called far UVC. And these lamps are going to be available within a couple of years at low cost. This is going to be a solution for us in low income countries. And this is the far UVC range. These are all the lamps which are available. And they can be used in a different fashion, in a way that it suits each facility, each environment in the hospitals or in the clinics or in any area where you are suspecting infection spread is very, very high. And now this is called Shield AI. This is AI, artificial intelligence enabled lamp for the hospitals. This is how it works. You put the lamp on the wall, you can see the beam of blue light which is falling on the patient's bed. Continuously, it is going to disinfect because this is high touch area. Nurse will come, doctor will come, spread the organisms, the lamp will come on automatically and kill the organisms. So what is this far UV? It is a 222 nanometer wavelength UV, ultraviolet rays. Ordinary 254 nanometer is very harmful. So now they have this UV, which is far UV. It is called far UV. It's not just ordinary UV. So this is AI enabled, and these lamps, we are told, is very hopeful for low income countries that they are going to be available at low cost, and then we can use them environmentally friendly, they are safe, and you don't use any chemicals, and they are going to be a solution for us. So that is something we hope. And Public Health Ontario has a whole website to teach people to use these interventions, that at your house, if you have a patient, a cancer patient who's regularly going to the hospital, he will bring home MDR. So can you use this lamp and how to use it? So we learn this. How technology is changing human behavior. Somebody asked, would you prefer technology or would you prefer to go and change a human behavior as a low-cost intervention? Somebody said, no. Changing human behavior is very difficult. I would rather prefer the technology. What is the technology? This is an ordinary healthcare worker. He's mopping the floor in the hospital, but this is again the theater. It's not a corridor. So how do you do this? Can you properly clean this floor? You need these contraptions. And if they can be low cost and they can be available, and what we talked about, the UV lamp and the safe gas, hydrogen peroxide, plasma, all those are very expensive. So can we use these robots? Can the robots be low cost? That is a controversial question. Robo can be expensive. Robo will cause loss of jobs. So does it suit us? No, not really. This is a Tesla robo. It can clean very, very effectively and disinfect hospital floors within a few minutes with low cost. WHO, core components of infection prevention control programs. These are all the free resources for training. I can quickly show you all these free websites, CMS website. There is this website. And also this is a joke about sluicing the patients. This is NHS. They're saying, can we thoroughly wash the patient before we admit him into the ward. Let us wash him with the hypochlorite. Now, there are robos in the hospitals already in high-income countries. Can the robos also spread infection? How do you disinfect them? That is a question somebody is asking. We have many guidelines, and these guidelines are really not helping us because they keep changing. We don't need more guidelines, but we need to integrate them into clinical standard operating procedures so that you don't have a separate IPC practitioner, a physician, and another pharmacist, another one. In low income countries, it won't work to have 4 specialists. We can have an integrated specialist who has integrated standard operating procedures, which is for antibiotic stewardship, IPC, as well as clinical acumen is integrated into these guidelines. It works on all fronts. So that is what we need. We don't need new guidelines. We have plenty of them. And then what is the guideline doing? There is recently, all of you are aware, we used to have MRSA isolation precautions, which said that you isolate the patient, you have gowns, gloves, masks, and then keep him in a separate isolation room. That thing has reversed now. The guideline says you don't need to isolate this patient. It was not cost effective. It was most ineffective. The guideline has changed. So there are many, many publications about these guidelines during the pandemic, after the pandemic, how the guideline did not work. We can skip through. And then came another publication about contaminated duodenoscope. This is the duodenoscope and how to decontaminate it. It has all these parts. Very complicated issue, how to decontaminate, how to clean them is very difficult. So you have the machines. Now these machines are very expensive to use, and sometimes they also don't effectively clean. These are the machines, but if these machines can be available at low cost, it can really help us. So this is something WHO and the world bodies can do to bring this technology to the low-income countries at a low cost. Now, look at these gadgets. These are the reusable stainless steel instruments. Very difficult to clean. They're actually saying, hi, ha, 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 can you try to clean us? It is so difficult to clean these things. They are all used regularly in a healthcare environment, and very, very difficult, very challenging to use them. So these are single-use infection prevention techniques. Infection preventionists are advocating now for minimizing the use of these and how to reuse these gadgets. These are all the reusable gadgets. Because of low cost, countries have to reuse them. Another question we have, new perspective is, can the probiotics actually help us to wash and disinfect? So these are all the available probiotics. But right now they are very expensive. We need to bring the costs down so that we are able to actually make them available to the low-income countries. AI applications is another question. Artificial intelligence. Help low-income countries to use artificial intelligence and have some low-cost solutions. These are 10 applications of artificial intelligence, but I don't think as low-income countries, we are there to use this technology. We will be there in future, but not right now. And then they said this is a robo with artificial intelligence. It is hallucinating. Most of the artificial intelligence stuff, when you ask a difficult question, it hallucinates. So somebody is saying it tends to hallucinate its own facts. What should we do? Then a nurse is telling, run it for presidency. So that is an American joke. Okay, water. What is the source of water infection spread? Water is a big source of infection spread, and a lot of ICU infections are now waterborne pathogens like Stenotrophomonas maltophilia. You have Pseudomonas. There are many other waterborne organisms. And then infection control in the splash zone. Some of the ICUs in the USA removed the water sinks to eliminate certain infections. So this is the hospital hub, which says, could intensive care units become water-free zones, remove water, and then control those infections? But as this hospital was asking, remove water from the ICUs, they were flooded. This was a hospital in, I think, Texas, Houston. Last year, this year again, they had heavy flooding. This year it was worse and many people died in the flood. So how do you get rid of water then? This is about compliance and hand hygiene and behavior change. Then there is a debate about horizontal and vertical IPC interventions. There are horizontal interventions which are, universal precautions, something like vertical, single organism like MRSA precaution or TB precaution or blood-borne precaution. But this debate is actually not applicable to us in low resource setting. Actually, a sound IPC program will combine both to save resources. Vertical programs are very expensive. They are single track, whereas universal precautions will help us to prevent many organisms. That is, if you use rotavirus vaccine, you only prevent rotavirus diarrhea. If you can provide with the same cost safe water, you will prevent 20 waterborne pathogens, including polio. So that is what we are talking about. So there are many scaling strategies, horizontal, vertical. We don't need to debate about it. Compliance IP measures is very low. We said single-use devices is another big problem. Should we use the expensive devices which we use in cardiology, reuse them? How do you reuse them? To reuse them is a very tricky issue. It is a ethical dilemma. And then again, human behavior is involved here. If you tell humans not to do something as shown in this slide, don't climb, everybody climbed on the pipe. They said play around the pipe, don't climb, everybody climbed. And then you have multi-resistant healthcare worker. He is resistant to guidelines, he is resistant to compliance, he is resistant to audit, he is resistant to hand washing, he doesn't want to listen to the nurses. So which practice is the most effective? Hand hygiene. Hand hygiene. If you have alcohol, if you have water and soap, you can practice. Conclusions. What is the conclusion about cleanliness? Leadership. Both infection control practitioners and cleaners, leadership to drive, sustain processes, reduce environmental contamination, and also prevent infections. Okay, what will happen? What is the future for us? Some of these problems will be solved by time, but some of them will stay with us. We have to live with them. We have to learn to live with them. IPC teams need to expand their physical boundaries. They shouldn't confine themselves to the clinics and hospitals. They should go out and work with the communities, educate the communities, empower the communities so that their work is augmented. They need to learn more, think more, read more, and be on the ground. There is more need than ever for highly motivated, well-trained professionals who can spot quickly what is going wrong and who are masters of communication with clinical counterparts. They should be able to communicate with the patients and also the policymakers and also the bosses, and at all levels, down and up, both sides, they should be effective communicators. And how do you empower yourself? Knowledge and wisdom. And what is in our way to HIA-free future? For us to climb this ladder, nothing really. Most important method is, again, hand washing, hand hygiene. Thank you so much for your attention.
Great. Thank you so much, Prof, for that very engaging presentation and insightful. I think you've provided a compelling overview of real-world opportunities as well as the challenges that are there in terms of implementing IPC in low-resource settings, and also how these efforts align with some of the already available AMR containment strategies that are out there. Your insights have also highlighted the importance of leadership, local ownership, as well as continuous capacity building that you've mentioned even just recently as drivers of effective IPC programs, even though our resources may be stretched. So we have received a few questions and comments in the chat. I'll begin with a few comments. I think there are some greetings to you, Prof. from some of the people that you met in the course of your work. There's a greetings from Nutin from Benin.
I'm blessed today, really.
Yes, who says he met you in 2020, where you are currently. And also a greeting from Susan Kiambi, who says she's enjoying the great presentation from you and has acknowledged you as a mentor of hers. So we've also received a lot of requests for the links. I know your presentation has been very rich with a lot of links that are there. So we have also mentioned that we will be sharing these with everyone after the session.
Absolutely.
So great. So now I will just jump onto a few questions, maybe just starting off from the capacity building aspect. We have a question here from Simon Peter Olako, who is asking that where can one get access to postgraduate courses in IPC? If you have any idea or response for Peter.
IPC postgraduate courses, unfortunately, one has to go to the rich countries, developed countries, to do a master's program or something. We began a master's program in Kenya, one of the public universities. Yes, the curriculum was written, people have joined, and the one class is about to graduate. I think one class has actually graduated, I suppose. The limitation has been, you see, it's not just enough that you sit in a class, you have listened to some lectures, and then you sit an exam and you get a degree. But to practice, to get the hands-on experience, you need faculty who are working in hospitals and who are practicing all these things, and then they are teaching. And also during your course, you go and attach to a hospital which is practicing all these things. So that is what you need for those courses. Those who certify, for them to be really effective practitioners, competent practitioners. You need that training environment. Unfortunately, we have hospitals, but not at the higher level than what we currently practice. So it is possible to now step up these courses, take them to facilities, but the facilities should be able to showcase those practices. And then these practitioners get that level, they get grounded, then they can go higher with their practice. So we are beginning, it's a good start because a long journey has to begin with one step. So we have started the step. But at present, if somebody wants to do a proper master's course, unfortunately, they will have to go out to do a 2 or 3 years course where the practice is thoroughly watched, observed, and absorbed. South Africa has short courses, 3 months and 6 months. And yes, they give a very good perspective. Unfortunately, I think that is the truth.
Sure. No, thank you so much, Prof, for that. Hopefully that will also not only just help the person who was asking, but also others who, want to enter the field of IPC. So that is very well. So we also do have some researchers also listening in today. And we have a question from Lucy Obonyo Nyangao. I hope I'm pronouncing correctly. She says, hey, Prof, good to have you here. AMR is really crucial topic globally. I would like to know if there's any researcher, organization, or institute which can support a researcher working on traditional manure to replace the chemicals used as manual as a way to reduce antimicrobial resistance. So any leads? I don't know if you have any knowledge around that. So
This is information about funders. I
yes.
think there are compendium of funders. Again, these are websites which guides you which area of research is being funded by who. It's possible to find out. Actually, I can give you how to connect with our librarians. They have actually a compendium of research funding. Our research office actually circulates when the calls are there, and they so and so funds this area, so and so funds this area. So you can get connected with them and they can give you information so that you are able to apply when the calls are out. Definitely, yes. And that's a very good topic. Organic manure is a very good topic. That is a sustainable, way of food production. Yes.
Great. We also did share some links, so hopefully I should also access those, but we'll also share some links that we get from you. So yes, this is now a question coming from someone who's practicing IPC. So this is a question from Neka, who says, Prof, please, how can an IPC focal person who has conducted an assessment on IPC gaps in their facility cope when government is not supporting financially to fill the gaps that we identified? Very tough question.
Yes, yeah, because I think that is what I said. We have so many publications coming from US and UK. They come, they visit East Africa for 2 months, like I've shown you that slide, and they have written a book. And they say they have given us some solutions. There are no solutions. It is state's responsibility, because if our healthcare budget is 0.003, and yet the donors have poured millions of dollars into the country, and they are no longer ready to pour these dollars anymore. They have stopped. So it is state's responsibility to mobilize resources, plug some siphons here and there, and utilize whatever is available within the country. It should be possible. We have enough resources, definitely. Like the Bible said, there is enough for everybody's need. So I don't think I answered your question, but it is a state's responsibility, and we are stuck, I think, in low middle income countries. But it's not that our countries have this problem. I think developed countries are equally problem. That is what Trump is saying. All that was going on in America, there was huge corruption, and he's trying to correct it. Everybody says the same thing. So we don't know. I said time will bring these solutions. Definitely. Times are great. Young people are very active, and there's a lot of information. Things will move, I think. Yes, we have a lot of hope in future. Yes.
Sure, sure. And I guess also just trying to collaborate, you might be thinking you are facing the same problem on your own, but maybe if you also try to reach out to other facilities and other places, you might find maybe they have solutions to some of the challenges you have. So collaborating, this is why we are also bringing people together so that they can also learn from each other as well.
You
So
see, that's what they said. Collaboration brings solutions. But you see, if I don't have water in my facility,
yeah,
which collaborator will give me water and soap? Really, soap he might give. He
yeah.
gives a can of liquid soap. He can't give me water. So that my state has to give me, my county has to give. Yeah.
Sure. So we also have some interesting questions here. The two questions there's one question from Luke Bet, who says, is there anybody here who has done antibiotics residues on ATM milk dispensers? Because I suspect it might be a notorious spreader of AMR. I don't know if this is
These are milk dispensers.
yes, ATM milk dispensers.
Why should we go to these dispensers? The milk itself has so much antibiotics. Why do you want to go and waste our time and money which we don't have on the milk dispensers? Just check the milk has plenty of antibiotics, because I showed you 100 kilos of fluoxetine. The farmer just throws on the farm when he has an infection in one cow or one goat. And then milk is full of antibiotics, including cholesterol, fluoxetine, what have you. So dispensers, really, we don't waste our time and resources on that. I don't advise you to do that.
Sure. And then there's a question from Denix Kivuva, who says, hey, Prof, thanks for the great talk. There are clinical diagnostic labs who have decommissioned and banned the use of UV for disinfection in their facilities, citing health and safety concerns. What is your take on this?
It's not my take. I have shown you on the slide. You see, the UV light is harmful. That is 254 wavelength. Is very harmful. It really eats away the cornea. One can become blind. It can go into the tissues. It penetrates. So the UV, which I have shown you, the low cost UV, which is in practice now, is far UVC. That is, it is 222. It's not 254. It doesn't penetrate, but it kills viruses and bacteria. So that is the UV we are talking about. It's science. It's not what I take and you take. It's science, and it is about facts. So its safety has been proved. It has been experimentally seen, it has gone through trials, and it is now ready for FDA approval. But the trials are going on in, I think, almost 150 hospitals, and then they found it very safe. Yes, we have to roll it out and then still monitor the safety. But so far, it has disinfected the common organisms in the patient area, even social settings. Some restaurant where a lot of people gather during COVID, they started using it, and it is really very safe. So that is the UVC we are talking about, the gadgets I have shown you, and that will be our boon if it is available at low cost. That's our hope. Yes.
Sure. And I think related to that as well, I think there's a question from Simon, who's saying, or he's saying, which hospital areas, based according to research, would probably benefit most from UV light sterilization?
UV light is not sterilizing, it is disinfection. You should know the difference between sterilization and disinfection. These are fundamentals at IPC. Back to the basics and back to school. So these UV lamps are applicable everywhere. They are used in the hospital wards, in the clinics, waiting areas where a lot of crowd is there, like you have a sputum booth or a toilet where a TB patient has gone inside. He may be sneezing and then there may be bacteria. So the AI enabled lamp switches on. When a person goes in, comes out, the lamp automatically switches on and then disinfects the environment. It's not only surfaces, it is also the air quality, because these are airborne pathogens, viruses like COVID virus. So somebody went inside the room, he's carrying these pathogens, and then now the lamp comes on, it disinfects within a few minutes, and then another person goes, it is safe. So this is applicable everywhere, including social gatherings, in homes, actually, where you have a chronic patient in a room, a cancer patient, a diabetic, whatever. It is applicable everywhere. Yes, in a OT, in a neurology theater, you will definitely use something else. You won't trust just these things, but they are still useful. If you are in a bone marrow transplantation unit, you need complete sterilization. So you will go for laminar flows and other technologies, but you will still combine this with those technologies. I hope I made it clear.
Sure. Thank you so much. Due to time considerations, we'd really like to take this opportunity to thank everyone who has shared questions and comments. And at this point, I really like to invite our presenter, Prof. Revathi, just to share any brief closing remarks before we wrap up.
Thank you so much. I'm very grateful to everybody who joined and listened to me this afternoon, and also asked so many stimulating questions. So all these free resources are available. My objective is to make people think, make people read, get empowered with knowledge. Yes, we may not have resources, but knowledge still helps us to protect ourselves, to protect our patients and our communities. And keep looking out for the opportunities. There are many opportunities, and the world will not remain, with the funding resource crunch forever. Things will improve. Time will bring many solutions, but be on the lookout, be ready to grab the opportunity. That is, you are at the bus stop at the right station, and the bus comes for a few minutes, you can hop on the bus. So that should be the philosophy. All the blessings to everybody. Our young, sharp minds, definitely all my blessings.
Thank
And
you so much.
anytime ask questions, send us the questions, we'll still answer them. It's not that it's just this 1 hour and we don't have the opportunity. Send the questions to Sylvester, he can forward, and all the links definitely he will share with you.
Thank you once again, Prof. Revathi. Before we close, please note that the certificate download code will be sent to you via email. And also, if you have not registered to become a member of ASLM, we encourage you to do so using the link or the website. You can navigate to the ASLM website. This will also ensure that you stay updated and continue to access the valuable resources via the ASLM website and the ASLM Academy. It has truly been a valuable session. As always, we are looking for ways to grow our collective knowledge. So stay tuned for more upcoming AMR CoP webinars on critical topics related to AMR surveillance. Wishing you a great rest of the day and a weekend ahead. Until next
Thank
time,
you.
bye for
Thank you,
now.
everyone. Thank you, SLM and Sylvester. Blessings to all.